Hello, and welcome to another video about dementia, aimed at those unpaid carers who are doing their best but might have received little or no guidance thus far. In this video, I'm going to talk about 4 behaviours, the names of which you might have heard. I'll explain them in the context of dementia care. Distress, delusions, hallucinations, and agitation. I'll explore the 4 behaviours. They can be frightening, confusing, and emotionally overwhelming. But they're not random, and they are often signs of an unmet need. I'll walk you through what they look like, what you can do when it's time to involve a medical professional. Medical professionals use the words with confidence frequently and seem to know exactly what each mean. Most of the time, they never stop to check if you know what they mean. This video might help you add the 4 words to your own vocabulary, differentiate them, and to speak them with confidence. Some behaviours respond beautifully to reassurance, grounding, and small environmental changes. Others need professional support. Neither is failure, both are part of good care. Before dementia, your relationship with the person you love may have been adult to adult, spouse to spouse, parent to child, friend to friend. In those relationships, negotiation, compromise, even argument were normal ways of resolving matters. But dementia changes that dynamic. The person living with dementia can no longer adapt their thinking or communication in the way they once could. That means the only person left in the room who can change their approach is, well, the carer. This isn't about blame, it's about understanding the new landscape. And there is excellent guidance out there, the NHS website, Alzheimer's UK website, the Kate Dementia videos from Newcastle University, the wonderful UCLA Dementia Care videos, and many more. They all helped me to change me. Perhaps when you finish this video, you might want to explore some of those resources and look for others of your own. So let's start with distress. It's an emotional pain expressed through behaviour. Distress is the most common behavioural change. These behavioural changes happen because the person with dementia can't explain what's wrong. So what does it look like? Well, perhaps tearfulness, withdrawal, repeated questions, pacing, clinging or calling out, sudden fearfulness, statements like, I want to go home, or it's time for me to go to work. And what can carers do? Well, first, slow everything down, validate their feeling, reduce noise and clutter. Offer support, grounding, check for pain, infection, hunger, fatigue. Respond to emotion, not to words. Your tone, pace, and presence all matter more than your words. Grounding and reassurance often work better than explanations. Sometimes self-help, referring to broadening your own knowledge, can help you to improve your caring. Kate from Newcastle University and UCLA videos show excellent examples of responding to distress calmly and effectively. You might learn something that you didn't previously know about. Distress settles with reassurance. You can clear environmental triggers. The person with dementia responds to familiar or predictable words. But there might also be times when it's wise to seek help from professionals, maybe a GP, nurse, professional carer, speech and language therapist, occupational therapist, and many others. Sudden or prolonged distress always deserves a professional check, especially if you feel out of your depth. So if any of these apply, seek help. If it lasts more than a few days, if things escalate despite reassurance, if it affects their eating, drinking, or sleeping, if you suspect pain, infection, or delirium, if your loved one becomes fearful of others, or if you yourself feel overwhelmed. Moving on to the next of the 4 behaviours, delusions. They're not chosen, they're the brain trying to make sense of a world that no longer fits, believing something to be true that is not true, not based in reality, often fear-driven and hard to shift with logic. These beliefs feel absolutely real to the person, and arguing rarely helps. And what do they look like? Someone stole my things. You're not my real partner. I'm being watched or followed. Misreading shadows and noises. I need to go to work. And what can the carer do? The goal isn't to correct the belief, it's to reduce the fear, avoid arguing, validate their emotion, reassure with tone and presence, gently redirect. Check for triggers and keep routines steady. And developing your own knowledge about delusions could help you further. You might come across techniques like verbal judo, which can be quite transformative. And there can also be times to go to the professional, as delusions can be linked to infection, sensory changes, or medication effects, all worth checking and not something the carer can do themselves. Perhaps when you observe delusions that cause fear, panic, aggression, feature unsafe accusations, arise suddenly or more intensely than feels normal, that disrupts sleep or daily life, or if you feel blamed or worn down. Here's just one rather amusing, I think, example of a delusion that happened to me. We'd just finished dinner. My wife stood by the TV, turned it off. She kindly but assertively thanked me for coming round and said it was time for me to go now. She thought I was just a friend who wanted to be a boyfriend and was taking care not to give me any unwanted signals. For me, it was lovely to see that her moral centre of gravity was still in place, but I had to hide my amusement and then change the subject. I got up, walked out of the room, and came back in through another door. And I said, I'm making a cup of tea. Do you want one, darling? So let's move to hallucinations. They're more common in Lewy body dementia, but can appear in any and all types. Your calmness is the anchor here. A hallucination is when the person with dementia is seeing, hearing, or sensing things that are not there. It feels so real to the person. But it can also be neutral, comforting, or frightening. They might be seeing people or animals, hearing voices or music, feeling touched, or misreading reflections or patterns. My poor wife's hallucinations often involve seeing hands coming up from the carpet, trying to drag her down into the inferno of hell. The carer should stay calm, validate the experience, adjust lighting and noise if that helps, offer grounding, and at all costs avoid saying there's nothing there. Dismissing the experience can increase fear. Validation reduces it. Learning more about hallucinations might be quite challenging if you're not already a medical professional. And sometimes the hallucination isn't distressing, and that's okay. So it's more likely you'll have to seek professional help, as I did. Start with your GP, get an appointment as soon as possible, even if it's just on the phone or by email. Hallucinations can signal infection, dehydration, medical issues. They certainly can be frightening. They certainly can include unsafe behaviour. They can become sudden or worsening. They can indicate fever, confusion, or a sudden decline in health, and always when the carer feels out of their depth. So seeing your GP, you may find that you are referred to a specialist consultant who will have even more expertise than your GP. This happened to my wife and I, and she was eventually prescribed risperidone. And finally, let's look at agitation, which is not usually a communication of discomfort. These behaviours are exhausting. Restlessness or emotional overload, movement, tone, behaviour, often triggered by an unmet need, but not always. Agitation looks like pacing, wandering, irritability, resisting care, talking to the person in the mirror, and repeatedly reassuring the person in the mirror, sudden anger or fear. When you observe agitation, your approach is key. Slow the pace, don't argue, simplify choices, offer movement, check for pain or boredom, use predictable routines. Avoid rushing care. Personal care is often a major trigger, so slowing it down can prevent escalation. Learning about agitation through the videos I've mentioned might be one of the most valuable things you ever do as a carer. Both Kate and UCLA videos show what's commonly done, followed by what's the best way to deal with it. You might hear things like, it happens in late afternoon. You might start to notice triggers. Getting them up and moving around helps. Reassurance settles them. Following familiar patterns is important. Agitation does happen throughout a person's dementia journey, and a change in agitation levels or intensity or duration might signal to a trained medical professional that the care needs to move on to a new level. They'll guide you, but you'll have to be able to communicate it to them in the first place, especially if any of these apply. Aggression, unsafe, sudden or intensity, lasting days, not hours, disrupting sleep or your ability to carry out personal care. Agitation that appears suddenly always deserves a medical check. So these 4 behaviours you can think about as a spectrum. They might overlap. They might present in different ways throughout the dementia journey. And being able to converse confidently with medical professionals will help you to help your loved one. As a rule, with all of these behaviours, it's best not to contradict the person with dementia. Don't argue or criticise with them in any way. If possible, after making sure the environment is safe, work gently and lovingly with them and use reassurance. And if you can, use distraction. The behaviours are a sign of an unmet need that they cannot verbalise. They're not signs of your failure. They're not signs of their failure. They're messages from a brain under strain. With the right support, both you and the person you love can feel safer, calmer, and more connected. Thank you for listening. The ideas in this video are mine, born of lived experience. If they help you, great. If they don't, perhaps they'll move you closer to your own ideas of what you should do right now and what matters to you and your loved one with dementia. And of course, I recognise that each person's formal diagnosis comes at a different stage of dementia, and that there are many different types of dementia where these 4 behaviours are more or less extreme, more or less common. If this video has proved useful, please pass it on to the next person you meet who is a carer or a newly diagnosed person living with dementia.